So in closing, I want people to look into the future a little bit. And Richard, I'll start with you about how will the future, with increasing early diagnosis of AD and targeted therapies, change the treatment of Alzheimer's disease?
So just like any chronic disease associated with age, whether we talk about Alzheimer's, whether we talk about diabetes, whether we talk about hypertension, there's always multiple strategies. With high blood pressure, you have the ACE inhibitors, you have the ARBs, you have the beta blockers, the calcium channel blockers, but you also have the non-pharmacological approaches. You have the low sodium diet and the low carb diet and the Mediterranean style. And there's all these different interventions, plus exercise. And the synergy together is the standard of care. If I had to use my crystal ball, this will be the same thing with Alzheimer's disease. Now, will the amyloid therapies be a pill? Will it be an infusion? We don't know yet, but we're going to have those answers. Are we going to start those anti-amyloid therapies when someone has symptoms, when someone is not having symptoms? We don't know yet, but we'll have those answers. So the first part of this complex puzzle of the multimodal treatment of Alzheimer's disease is before us, and in a few years we'll know. And until that time, we need to keep thinking about other targets as well, whether it's neuroinflammation, the antiviral approach, whatever it is from a pharmacological perspective, we're going to figure that out too. And then finally, the non-pharmacological strategies. Exercise. When do we need to start it? How much exercise? How much weight training? How much cardio? We don't know these exact answers. For the next 4, 5, 6, 7, and maximum 10 years, we should have a multimodal management plan for Alzheimer's disease.
That's great. Marwan, anything to add in terms of your crystal ball of the future management of Alzheimer's disease?
I want to jump off on Richard's comments to say that in our lifetime, in the fairly near future, we will transform Alzheimer's dementia from a terminal disease as we know it to a chronic disease. This is the diabetes and HIV of our time, and I think we will enjoy the success of seeing that happen. I don't think that's a generational thing. The idea of curing it, I think that is a generational thing. The idea of preventing it, I think we're a little bit further out, but the first iteration will be transform into a chronic disease. The second iteration will be to identify people at risk so that we can deploy a prevention strategy around those people. So the future, we've had a run of very negative results, right? We've had a lot of drugs fail in the last 18 months, real disappointment in the field, real discouragement in the field. But I still think that we're very close, closer than we've ever been. And I think that there are ways forward are in front of us.
Ali, anything that you would add about the future of Alzheimer care?
It's going to go towards precision medicine and personalized medicine. And I think we are at a tipping point in some ways of 20 years of work on biomarkers are coming together. We have computational power, other ways of actually seeing that. And once we are better at having different biomarkers of whether someone has the disease state, whether this is causing neurodegeneration, whether this is how they may respond to different therapies. Once we have a better handle of how to measure those things, I think we can more rapidly actually look at drugs and combinations. And I think ultimately it's going to be a combination of drugs and lifestyles, multiple combinations at different stages and I think we'll get there. I agree with you, Marwan. But I think, the idea of cure, taking somebody who is in the brain failure stages and reverting the clock back, I think that's something that is many decades away, but I think we can have very meaningful therapies that in the next 10 to 15 years that will change the course of this disease.
And Elaine, how about you? Do you have other views of what might happen in the future?
A little bit. I think there will be combination therapies, not only addressing amyloid, but also tau and perhaps synaptic loss, either to restore synapses, support and grow new synapses. I think there may be mechanisms we know nothing about yet. And I think in the next 10 years, I think that will become much more apparent.
I'm kind of with you, Elaine. I think that there's going to be a broadening of the scope so that we will be getting epigenetic drugs and epigenetic information that may be very useful. this whole new class of senolytics that are addressing cellular aging and may have effects on multiple body systems, including the brain, I think is a very novel and innovative way of thinking about therapeutic intervention. So I think we're going to see both a focused, concerted precision medicine approach in Alzheimer's disease, but we're also going to see importing a lot of information into the Alzheimer's disease world as we understand normal aging better, and then integrating that with pathological aging. So this has been extremely informative. Wow, what a session. Before we end this discussion, I'd like to get final thoughts from each of our panelists. So Dr. Atri, could I ask you for some final thoughts?
I would say that I'll come back to the principles that I think about as what can we do now? What we can do now, the first stage is actually to detect and diagnose and have, at an earlier stage, empower patients and families to be involved in their own care. The second part is really strategies regarding non-pharmacological care, communication, behavior, environmental changes. The third strategy of the current therapies is pharmacological, and taking the bad drugs away, coming up with combinations of lifestyles and improved medicines to help. The fourth thing is really coming together with the care partner to implement this, because implementation really, really matters. And we need to spread the word that actually that this has value. And then the final component is, I think, research. That at every stage, we need to be able to understand this stuff. This is not, someone doesn't wake up one morning and says, I have MCI, and the next day they have Alzheimer's dementia. This is a continuum over decades, and we need greater engagement from all stakeholders in order to defeat this disease. This is not something that can be done by pharma by itself, by academia. We all need to be involved. I'm hopeful, and we are learning a lot, and I think we will get there. And I appreciate being part of things like this, so we can educate colleagues and increase engagement, so that people have proficiency and confidence about diagnosing and treating this disease and doing more research.
And Dr. Isaacson, some final thoughts?
So echo your exact points. I think the multimodal management strategy of Alzheimer's disease, from the spectrum of prevention to treatment, will evolve over the next decade or more. And I think it's an exciting time. I think a lot of people out there are losing hope with the failure after failure, but I don't see it as that at all. We had to learn. We had to create the baseline and the foundational knowledge to succeed. And I think we have that now. I also think it's important to reduce stigma around the disease. If someone is having a memory problem, it's okay, talk about it. I think in the United Kingdom, dementia-friendly communities, millions of people have been trained on how to interact with a person with dementia. And if someone's lost in the supermarket, well, have a conversation with them and identify that it's someone with dementia and help them out. So I think talking about things from a psychosocial perspective, from a stigma perspective, and getting primary care physicians and specialists to take this seriously. If someone has a mild memory glitch, well, it may be nothing, but it may be something. So the concept of worried well, I don't know if I love that term anymore. I think if someone is having something, have a conversation, take the next steps, and at least do an evaluation.
Very good. Dr. Peskin?
I have a couple of thoughts. One is we shouldn't forget people who already have Alzheimer's disease. More and more research is focusing on secondary prevention and even moving that back a little. I think we shouldn't forget providing the best care we can for patients who have the disease, and particularly in the later stage of the disease when behavior becomes such a problem. Also, I want to mention caregivers. And this is a disease that's often said to cause more suffering in caregivers than it does in the patients themselves. And just to remind people to take care of the caregivers, make sure that if they have depression, it's well treated, and to provide support services and referral to the Alzheimer's Association and all the things you need to do for the caregiver.
That's a great reminder. And Dr. Sabah, some final thoughts?
Yes, two. One is that Alzheimer's disease can be diagnosed. That we need to stop the idea that it's a diagnosis of exclusion, that the imprimatur is to move it toward a diagnosis of inclusion. The biology, technology, biomarkers exist. They're just not deployed in medical practice in the United States. They need to, physicians and neurologists in particular, need to be informed, because they're coming. Blood tests, CSF tests, imaging modalities are moving and transforming the landscape in which we can diagnose Alzheimer's accurately with greater than 90% accuracy in life, in vivo. And so that will be important so people don't have to think they're guessing. Second is that Alzheimer's disease can be treated. I hear over and over again the futility and nihilism that why bother even diagnosing, because you can't treat the disease. Nothing makes me more irritated. And I say this to you because people don't understand what the current treatments can do. They don't understand that they're symptomatic treatments. They do not stop the progression. And so when they see the patient getting worse, it's because they don't understand that they were going to get worse no matter what. But to understand that it's treatable, that when you treat a patient and their family and their caregiver that's in distress, and you're treating their sleep and their agitation and their wandering, and you're bringing social services and support to the patient and their family, that is treating the disease. It's not just a pill of a cholinesterase inhibitor or an NMDA antagonist. All of it is treatment of the disease. And the reason this is important is it's a paradigm shift. Physicians need to understand treating the disease means that when you have the next drug, like a BAN2401 or a gantenerumab or an L-inhibition stat, that we're already thinking in a treatment mindset so that we can just add to our treatment armamentarium a new drug. And so the idea is that conceptually you need to embrace the idea that Alzheimer's is treatable.
Great. Thank you. So I would add two things. One is that the multi-stakeholder collaboration is absolutely essential, and Ali, I think you mentioned this. We're facing a tsunami, and there's going to be enormous suffering with this disease unless we have better responses to it. And it's only going to be solved by policy changes and multi-stakeholder collaborations. And I think we can create a much better future for our patients and our caregivers than we are currently offering them. So thank you all for your contributions to this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative. Thank you.